Tourette, Tourette syndrome, Tourette's syndrome, Tourette's disorder. It's all the same thing. So you'll hear people get very confused about what Tourette is, but a variety of different names that doesn't really make a whole lot of difference. Diagnosis, motor and vocal tics, got to have them for a year. Don't really need to be impaired to get the diagnosis, just as long as you've got them. And most people are self-diagnosed. They read something, that somebody tells them something, they figure out who they are and what they got, and then they go to a doctor to get confirmation. And usually by the time a patient goes to a doctor to get confirmation, they know more about their condition than the doctor does. It's a very unsatisfying experience. That's why the Getting Started video is so valuable to people, because sometimes they'll go in a 15-minute visit. It's not hard to give a diagnosis of Tourette. If a kid's going, you're done. It takes 5 seconds to make that diagnosis. It takes about 6 hours to know what it means, which is what we're really going to do today. There's a chronic motor or vocal tic disorder. That's motor or vocal tics for more than a year. Brand new for the coming diagnosis. It used to be, if you ever read the diagnostic criteria, that you had to have, over a year's period of time, tics for 9 of the 12 months of a year. If you had it for 8 months, the doc would go, I don't know what you got. And then even if you had it for 9 months, you would need to go out to 12 months to look back that those 9 months were part of 9 out of 12. There's no doctor who's ever going to do any of that level of precision. So essentially what we've got now is if you have a first tic at age 6 and you have tics at 8, you have a chronic tic disorder. You could have had no tics for 3 months, 4 months, 5 months. We don't care. But if they're showing up every year of your life since first onset at age 6, you now have a condition if you've had a year of tics, if you will, from the first tic onset. And it's going to make it a lot easier for you guys to think about it and for docs to think about it. We also had this very unusual, we had transient tic disorder. We got rid of that too. And transient tic disorder used to be that you had tics of less than 8 months and they went away. So if you were doing your job, getting your young child in there after having tics for 3 or 4 months, the doc would say, well, I got to see you in a year to know what I can give you. Because if you think about the word transient, it means that they came and went, right? So if you've had them and you still have them and you're 4 months out, there was no diagnosis for that. So we now have what we call provisional tic disorder, which means that you currently have tics, but you haven't had them for a year since first tic onset. And the reason we want you to have them for a year is that we don't want to give that big diagnosis for something that really, for many kids, comes and goes. So we save that disorder diagnosis for somebody who's had tics persist over a period of time. Historical context, Tourette worked with a guy named Charcot, and they all, believe it or not, hung out with Freud. This was a very wonderful and select group of docs, famous docs. And Charcot was working on dystonia and other kind of movement disorders. Freud was curing hysterical blindness, hysterical paralysis by doing dream interpretation and free association. And so these people would come into the neurology clinic holding an arm like this. It wasn't working very well, and he would talk with them and do some free association, and then they would leave being able to move their arms again. Tourette identified this group of patients, a small group of patients, that had unusual movements and vocalizations. And so Charcot said to his student Tourette, go ahead, write that up. And, if it gets accepted for publication, we'll let you put your name on it. So that's what happened. He got his name on it. But at that time, since there was really no treatment for it, they all got sent over to Freud and his guys. So from the late 1800s, it was a psychological condition. 1965, or thereabouts, people began to use antipsychotic medicines, haloperidol and its relatives. And the tics go down pretty dramatically when you use antipsychotic medicines. So at that point, people said, this isn't a psychological condition. This isn't about kind of some event related to your mother. This is really about the brain. And you know what? It makes a lot of sense. And if we think about it as a brain disorder, it'll decrease the stigma that's associated with it. We can do research on it now. We really will free people up from trying to figure out what it is that at some point in their psychic life they or their family did to give them this condition. They don't have to do that anymore. This is a brain-based neurologic condition. With the advent of a treatment, what you see happening, what doctors always do, is if I've got a condition and I have a brand new treatment for it, I begin to look for cases. I hunt them down. So in 1965, there were about 100 cases in the literature. Now we're estimating that tics occur in about 20% of school-age kids. 1% of kids will have Tourette, 1 in 100. Very common. But it's simply because we have a treatment, right? Once you get a treatment, then your threshold for diagnosis goes way down because you're trying to find cases that could potentially benefit from the treatment. As they began to identify cases, they began to see this interesting pattern that Tourette occurred in each generation. So dad or mom had it, junior had it, grandpa had it. There are conditions that skip generations. So grandma and grandpa had it, mom and dad don't, junior has it. That's like cystic fibrosis. Those are recessive, disorders that require a mom and a dad to both contribute a gene. This disorder looked like if you got one gene from either your mom or from your dad that you would get this condition. And so the idea was this is going to be easy finding this gene thing because it's autosomal dominant, meaning it passes from one generation to the next and all you need is one copy. So as people began to look at families where there were multiple people affected, they also identified these other conditions, ADHD, OCD, anxiety, depression in older folks. So it started off psychological, became purely neurological on the tic side, but became neuropsychiatric because this is a condition that actually tracks with psychiatric disorders. Those early genetic studies actually demonstrated that it really is a genetic condition. But when you look at identical twins, right, where one twin has Tourette, the other twin doesn't have exactly the same Tourette that his co-twin has, often milder. And there was one study that actually suggested that the lower birth weight twin of the two twins had more severe symptoms. So maybe there was something going on in that intrauterine environment that put one twin at more risk for severe symptoms than the other, which brings up the idea that the environment, whether it's the intrauterine environment or the external environment, has something to do with, not with whether you're going to get it or not, but maybe how severe it is. Does that make sense? And then, because every advance in Tourette syndrome has occurred in response to a treatment advance, with the advent of efficacy for the behavioral treatment, we now think of it as a behavioral and functional disorder 2, not instead, but 2. So this is a neurologic disorder, genetic, shaped by the environment, that also gets elaborated or complicated by behavioral forces. And by undoing or working on those behavioral forces, you can actually manage the manifestation of this neurologic and genetic condition. Does that make sense? So if you were to go to a doctor and you had diabetes, God forbid, the doctor would say insulin, diet, and exercise. It's a biological condition. You can't just do insulin. You've got to do diet and exercise too. Tourette is a neurologic condition. You got to do diet and exercise too. That's all we're saying. Does that make sense? Right? You got heart disease, you got to lower your blood pressure, but you also got to change your diet, and you got to start exercising. So much of medicine is built this way. So we shouldn't be surprised as we see this evolution over time that we are now at a place where we're thinking about a comprehensive understanding of what Tourette syndrome is. Neurologic, genetic, no question, shaped by the environment, plus managing the environment can also increase tic severity. So the behavioral and functional part, where does this come from? Well, adults with Tourette syndrome use behavioral strategies. They will tell you over and over again that they've figured out ways to manage their tics in certain situations. Why shouldn't we bottle that, put it into a manual, and train 6, 7, 8, 9-year-olds how to use those strategies so they don't have to figure them out on their own? Why redefine the wheel, if you will, when we can manualize that and train kids to do it? When I think about behaviors, I think about things that come before the behavior itself and the consequences, ABCs. And so that's a new language that everybody's going to have to learn if they're going to really be part of the kind of Tourette syndrome family, if you will, and understand really how best to manage tics. Tic severity can be reduced by behavioral strategies. And then tics also have a function. This is one of my favorite ones. I got a million stories about how tics in interaction get shaped by those interactions. Course starts in young kids, starts with motor tics, then vocal, starts in the head and the face, then moves to the body, starts quite simply, oftentimes with eye blinking, then more complex tics. Peak severity is in the early to mid-teens. Some people think about it as a hormonal disease. It really is pre-hormonal. Anxiety, depression, moodiness, that's teenage stuff. That's around that time. But not the tics themselves. The tics are before that, 6, 7, 8, 9. The development of those comorbid conditions occurs later. The prevalence actually of, or incidence of the comorbid stuff climbs into adulthood, whereas the incidence of tics drops off early. Very few people have poor outcomes. Very few. So when you see someone who's really struggling and has a poor outcome, I think a lot about kind of what their assessment has been, what's not been gotten to, what's been not looked at, what treatments have not been tried, kind of how treatment has been staged and organized, because the vast majority of people with tics do pretty well. This is worse tic severity and age. If you look at it, it's 10 to 11 to 12, and then it gets better over time. So if you see somebody, again, at 17 that had mild tics, but all of a sudden they have their worst tics ever at age 17, doesn't look right. So what doctors do is we do pattern recognition. So the pattern in my head is 6, 7, 8, 9, 10, worse around that time, got to find a way to get that youngster through that. By the time they move into adolescence, they're going to get better. If they're not getting better, something is happening. Or if they're getting worse at a particular time in adolescence or even in adulthood, something else is happening. That is not the tic condition itself, if you will. Okay, so this is the repetitive behaviors, right? This is all the neurologic words. None of these things look like tics. Chorea is, that's not tics. Myoclonus is a big single jerk. Tremor. Dystonia is a fixed position. Athetosis is a lot like chorea. Sometimes they call it choreoathetosis, big movements. Spasms, I get them all the time. I get them in my eyelid. I get them in my legs, tired muscles. And then dyskinesias. These are bigger kind of motor movements, and they're often truncal. They're not really the wild choreatic or athetotic, but they're more truncal kinds of movements. Very different. It's not easy. It's not hard for a doc to differentiate these from Tourette. Now, some people with these also have tics. So there's a nice association between people who have dystonia. They also have tics. On the psychiatric side, we got a whole bunch of things that repeat. And that differentiation and sorting has gotten very complicated. And we've probably led families and kids and adults astray a little bit by not using very precise language to describe what it is we're seeing over here. How many people? Less than 100 cases in the 60s, 1 in 100 to 1 in 10,000, probably in adulthood. Up to 20-25% of school-age kids will tick. The reason why that's important is I use the tick as a marker of neurodevelopmental disturbance. So if you go to your pediatrician and he says, it's just a couple of ticks, don't worry about it, I would say to that pediatrician, do me a favor, and can we monitor him over the next 3, 6, 9 months, 12 months for symptoms of ADHD, symptoms of anxiety, symptoms of obsessive-compulsive disorder, because when I see a tick, that tick clues me into that this youngster may have neurodevelopmental disturbance in other areas. And I don't want to just dismiss the ticks, because once I dismiss the tick, I'm dismissing the risk for what these other conditions might be and how they may affect the young person. I see teenagers who are often depressed 3 to 4 years before somebody picks it up. Anxiety disorders in our behavioral treatment study, 30% of the kids who came into our tick treatment study had undiagnosed anxiety disorders. We picked it up. They were in treatment with somebody. 30% missed the anxiety disorder. So what's changed? Well, we have more awareness. We're focusing on milder symptoms. I see kids who come in now, they've had blinking for 6 weeks. It's a little too early to say much. Probably it'll go away. Is it inherited? Yep, we talked about that. It's probably much more complicated. It's probably a multi-gene disorder. And so far, we don't have really many good leads about where the gene is or a gene that might be responsible. We have a couple of clues or hints. It is genetic. There's no question about that. But just how that's going to work, I think our appreciation for how complicated the genetics of these conditions are is increasing. And I think a more sobering kind of sense about what we'll find by doing genetic studies. But what's the most important thing when somebody says, is it inherited or will my kids have it? The most important thing is when a family says, what is our risk for having children with Tourette? I have a much more complicated answer, as you might already guess. What info can you give me that prepares me for having a child with Tourette? I have not met anybody who has Tourette who's decided not to have children because they have Tourette. And they shouldn't. Because the range of severity, even if you're genetically affected, could be on the extremely mild and gone by age 15, 16, 17. And we have decent treatments if it is there. So that one for me should be a no-brainer for most families. On the other hand, if dad's got depression, mom's got OCD and Tourette, or vice versa, now we got something to talk about. We got an anxious risk to talk about. We got a depression risk to talk about. I see all kinds of people with Tourette functioning extremely well. I do not see many people with severe untreated depression working very well. Or children with anxiety, moderate to severe anxiety, they accumulate impairment prior to puberty that's pretty substantial. So to focus on the tics, when the tics are really just a marker for these other conditions, kind of sends you off in the wrong direction of worry. Does that make sense? So that's the point, is if there's just tics, I don't get too excited about that. I get excited about the comorbidity. But the pattern of care seeking starts with the tic. The tic is the calling card to the doctor. And what I'm trying to get you guys to think about is that don't get tic focused. Focus on the whole child and focus on the co-occurring conditions that actually are associated with real impairment over time and accumulate in frequency. The incidence climbs in adolescence and into adulthood. The incidence of Tourette decreases in the mid-teenage years. I see tic doctors, experts, miss conditions. The 30% of the kids who came in our behavioral treatment study, they missed the anxiety. And they were taken care of in New York City by good doctors. That's why I'm doing this today. I'm not trying to, I'm alerting you to the mistakes that people make by becoming tic focused. They miss the comorbid conditions. That's the whole day. And you can make your life and your kid's life better if you focus on not just your tics, but on your comorbid conditions. Anxiety, affective illness, the other conditions which are highly treatable but are also impairing. So ADHD, OCD, other anxiety, substance abuse. Substance abuse for me is the dirty secret of Tourette. Teens, when they discover that their body's quiet under the pressure of marijuana or alcohol, it is really hard to convince them to not keep doing that stuff. And yet they get into a lot of trouble. Children, risk associated with poor parenting and untreated parental psychopathology. What the heck is that? So this is the speech about when you're in the airplane and they say, you know, if you've got a child with you, put your own oxygen mask on first. I can't tell you how many parents I've seen dragging their kid in to see the 30th doctor, and dad's depressed, mom's depressed, you know, nobody's working, life is terrible, but they're going to do everything they can to get Junior to see that next expert, and they haven't done the necessary stuff to take care of themselves or to take care of their marriage. Your kid will do fine if you put your own oxygen mask on first. Get the care you need. Make sure your marriage is in decent shape. Your child depends upon you to be functioning, powerful, strong. They will mimic your health-seeking behavior, care-seeking behavior. So if you seek care for yourself and you get better as a result of that and you feel good about your interactions with clinicians, guess what? They're going to be interested in doing the same kind of thing, getting into care, following doctor's orders, doing what they need to do. So what I tend to see, on the other hand, is kids get treated first, because that's kind of what parents are focused on, and then maybe parents begin to pay attention to the stuff that matters. This creates this difficulty, problems with parenting and untreated parental psychopathology, creates environments that over the long haul is detrimental to tics, ADHD, anxiety in general. So the risk for severe and protracted Tourette, very low. Less than 10% move into adulthood with severe conditions. Even if you look at medication claims data, in the last year we looked at private insurance versus federal government insurance. It's closer to 1 in 10,000, 1.5 in 10,000 kids actually get a diagnosis and get treatment for tics in any given year. So there's lots of kids who have tics but aren't necessarily pharmacologically treated for their tics, or where the tic disorder diagnosis is the primary diagnosis in the doctor's office. Most with good coping and self-control skills can manage their illnesses well. When you see Peter Hollenbeck, Paul DeVore, these are people who have pretty significant symptoms, and these are people who have been enormously successful over their lifetime. When you meet them, these are people of high-quality character. They have good emotion and behavior control. They can't control their motor movements, but you think about everything else that they work on, that they can work on, that they have some capacity to master. They've mastered that stuff. So when I think about what do I do with a kid who's got Tourette syndrome, I want them to master everything that they can control, because they have something that they can't control. Yeah, we want the world to be nice to them about that, but while we're waiting for the world to come around to, get on board with us, in the meantime, we can be helping kids become competent, strong human beings, so that when they have problems with their tics or these other conditions develop, they'll be ready to go in this world. So what do? Counseling for families and parents needs to be comprehensive. It's not just about tics. Discuss all the risks for and benefits to children. Focus on what can be done to ensure happy family life. I see people who are very depressed about having a kid with Tourette. Kid's happy, fine, going to school. He's got 1 million friends, getting decent grades. Yeah, some nights he gets bad. The family's just... Focus on happy family life. Coping and self-control skills are absolutely key and not directly genetically controlled. It's something moms and dads can work on. There's something happens to parents when they have a kid with Tourette. They take 3 steps back and they say, I don't know what to do. And in that vacuum, Junior knows what to do. He does whatever he dang well pleases. So there's something about having this condition that takes parents out of their game. They can continue to parent all the other children, but that one, I don't know about that one. I don't know what to do with that one. when probably you ought to do with that one what you do with all the others. There are also difficulties. There's probably secondary self-consciousness to having tics, so other kinds of anxiety. Having a chronic condition of any type could kind of take you out of your game and make you a little bit unhappy, short of a major depressive episode. People with Tourette probably have more difficulty with managing impulses, even if they don't have ADHD. I describe it as the thin stimulus barrier. It's this idea that if I'm asking a patient whether they got eye blinks, they usually blink, and if I ask them if they have any nose wrinkles and do that, then they imitate me. They're extremely sensitive to that kind of trigger. They don't like collars, turtlenecks, ribs in their socks. So there's stuff like that that's kind of part of that thin stimulus barrier. And that really goes to a kind of more fundamental problem with impulsive behavior control that's more subtle and not just tic-related. And then those with ADHD oftentimes have problems with learning. But, if you've got a lot of eye blinks, it's going to be hard to read. If you've got a hand jerk movement, it's going to be hard to write. So there's lots of impairment that can come simply from that's quite tic-specific. So how do I sort all this out? I assume and spend very little time on establishing the diagnosis of Tourette, ADHD, or OCD. It's a minute of the consultation. Because usually by the time they're coming to me, there's something else that somebody hasn't seen or addressed. Or there's issues with symptom confusion. Symptoms have been mislabeled, which means that they have been mistreated. They were labeled one thing and they got a treatment for that. I also look at family history. I also look at time course of symptom development. This, I think, will be helpful for you guys. And then I think about common things being common. And I see a lot of harm done by inaccurate assumptions. So these are the conditions that I look for in my clinic that other docs haven't picked up. So they got TS, ADHD, OCD, or some combination of that. But we see kids between 6 and 10 having separation anxiety disorder. These are kids who are afraid to be alone. They often have problems falling asleep at night. They get up in the middle of the night. They crawl into their parents' bed or they lay on the floor. Some people will call that OCD. It's not really OCD. It comes with an enormous amount of distress. They don't do sleepovers. They go to the nurse during the day at school because they're worried about something happening at home. They are anxious kids, the onset 6 to 10 years of age, and it often co-occurs with the onset of tics. So if you go to a tic-focused doctor and you have tics and separation anxiety, you may get your tics addressed, but you may not get your anxiety addressed. That's what gets missed. Other anxiety disorders, we see social anxiety disorders. Some kids with Tourette are shy. Some are not at all shy. So it's not something about tic per se, but we see kids who are really socially inhibited and socially anxious. Or generally worried. These are the kids who, I call them the what-if kids. They're always seeking reassurance. You can reassure them till you're blue in the face, and it just never makes the worry go away. They may be described as having OCD, but they probably have generalized anxiety disorder as opposed to obsessive-compulsive disorder. And I think I spend more time talking about the anxiety disorders. Pervasive developmental disorders, I tease people that I see more Asperger's in my tic and OCD clinic than they see in the Asperger's clinic. That's because people with Asperger's have repetitive behaviors and stereotypic motor movements, and people get confused by that, so they come into the tic-OC clinic trying to figure out what it is. So we make a lot of pervasive developmental disorder diagnoses in our clinic, not because they necessarily track together, but because those PDDs have movements and repetitive behaviors as part of them. The stuff in red is all pre-puberty. So when I have a kid who's under 12, I have a narrow list of things that I worry have been missed, if you will. These are the after 12, if you will. So major depression is what we see in teens and adults. Rare cases of bipolar disorder. Just think if you have the Tourette vulnerability plus bipolar disorder. But we've seen docs, patients come in again, where what they said is, well, this is just really bad Tourette syndrome, and they miss the bipolar disorder, which has a completely different treatment than tics do. There are, good personalities and not so good personalities. Go figure. Symptom confusion, repetitive behaviors and repetitive thoughts. Compulsions, So there are people who are trying to broaden OCD. I'm trying to narrow it. So when I think about a compulsion, the classic compulsion in a school-age kid is hand washing. Worries about dirt and germs and repetitive hand washing. These kids believe that if they don't wash their hands a certain number of times, or if they're left with germs, something bad's going to happen to them, something bad's going to happen to their family, they're going to die, they're going to get sick. They are just racked with worry. That's a compulsive behavior. What we see in tic disorders is oftentimes repetitive behaviors like touching the door jamb on the side equally. That's really responding to a sensation or an urge and is carried out with a motor movement, but usually doesn't have the same kind of catastrophic cognition, and it certainly doesn't rise to the same level of worry inside. You'll see the kid go through, you go in their house and the door jambs have little dirty smudges. You know, as they get older, it kind of moves up. But they've been doing that forever, and it doesn't bother them, not a big deal. There isn't the distress associated with it. It may bother the parents who see them doing it. Yeah, I get that. Stereotypies are repetitive movements. They're usually bilateral. So you see kids arch. You see them stim, self-stim. They do things to soothe themselves like rock. Those are repetitive movements, but they're stereotypies. And it's important to differentiate stereotypies from tics. Some people who have stereotypies also have tics. So sometimes you see both within the same patient. Kids with autism, pervasive developmental disorders also perseverate. What they do is they do the same thing over and over and over again, not because it's a repetitive behavior per se, but because they're deeply invested in the pattern of repetition. So repeatedly flushing the toilet to see the swirl. You can call that a compulsive behavior, but I would tend to call that much more of a perseverative behavior, and I would be thinking about autism and PDD as opposed to OCD. Addictive behaviors. I've heard about compulsive marijuana use. Right, they want OCD treatment for marijuana use. It's been done. Even AA and Al-Anon, the drug disorder people, they've used compulsion. But it's very different than that youngster who washes his hands repeatedly. We call them addictive behaviors. Makes it just a lot easier. And then habits. On the repetitive thought side, there's obsessions. There's the kind of the worry, intrusive, silly, nonsensical. The kids will say, you know, I have this idea. It pops into my head all the time. I don't want it. It doesn't make any sense. It's not about who I am. But I can't get the idea out of my head, and I think that the only way I can do it is if I do something magical, like wash my hands or count to 30 3 times or whatever. That is the obsessive thought. Ruminations is what depressed people do, and ruminations have a certain characteristic to them too. Depressed people worry about poverty, they worry about bowel disease, and they worry about brain disease. So when I hear about a 16-year-old with Tourette syndrome who feels like his mind is degenerating or diseased, I worry a lot about depression in that youngster because that is a classic rumination that you see with depression: brain disease, bowel disease, poverty. Delusions are fixed false belief. These are often not hard to find or to differentiate, but these are people who believe some on the very bizarre side, like, you know, this is actually a direct feed to the CIA. You didn't know that? We're all being watched. That would be delusional. Perseverative thoughts, what's perseverative? It's like how many fingers one, how many fingers one, right? That's how you test for perseveration neurologically. These kids get stuck in a behavior. It is not compulsive, it is stuck. And what we see happening with kids with Tourette and kids who are on the autism spectrum is they don't compulse, they get stuck. They have hard times making transitions away from activities. I tend to think of those as perseverative behaviors, completely different kind of treatment response than if it was an obsessive or compulsive issue. Cravings is what's associated with addiction. That feeling that you want alcohol or you want marijuana, that's a craving. That's not an obsession. Overvalued ideas, this is one of my favorite. Overvalued ideas are ideas that are common in the marketplace of ideas, if you will, but somebody just takes them a little too far. So if you think about anorexia, being thin and beautiful is terrific, right? You lose 30% of your body weight, not so good. You've taken that idea and gone way, 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 way too far. Now, there are some people who say, well, they're obsessed with fat, right? And so you'll see people with anorexia, just straight anorexia, get treated as if they have OCD, and they fail those treatments. There's no medication treatment really for anorexia. It's all behavioral. You can treat the comorbid depression. There are some people who have anorexia and OCD. There are people who have anorexia and tic disorders. So beginning to sort and parse that stuff out makes treatment a lot easier. It's not a parsimonious explanation. It is a complicated explanation. Most families want one word to tell the teacher. What's with your kid? Oh, he's got Tourette. And then you tell him he's got Tourette, and that means ADHD, OCD, learning problems, executive dysfunction. They want one label for that. But from a treater's point of view and as a consumer, you really don't want to think as having one. You want to think about each of the pieces and then identify the evidence-based treatments for those and make sure that your youngster or yourself are getting the evidence-based treatments for those specific pieces. Does that make sense? And it gets all mucked up. It gets all mucked up. And so you just have to be knowledgeable and careful, and that's kind of what we're trying to do today. Oh, flashbacks. That's what happens when you've been traumatized. You have intrusive ideas about the trauma popping back into your mind again. This is one of my favorite slides. So my job is really easy because many of the things that I present to me in my office present in a chronologic way. So this is the pervasive developmental disorder. I don't diagnose too many kids with autism at age 28. Got what I'm saying? Starts before 3, 4. You ought to be picking it up at 3 or 4. Maybe if it's in the mild or high functioning, 6, 7, and 8. I've seen some teenagers, some Asperger's teenagers at 16 or 17. But this is something that happens really early. If you have early abuse and neglect, so kids who are abused and neglected under 2, they're going to present with symptoms under 5. So when I'm seeing a kid under 5, I'm thinking about, well, maybe he's got a pervasive developmental disorder, maybe he's got abuse and neglect. There's some ADHD kids who present at 3 or 4, so I'll extend this group down. But most of the time, ADHD presents at 6 or 7 when kids go to school. Anxiety disorders in general are between 6 and 10, 6 and 11. Depression is mostly a mid-teenage disorder. Oppositional behavior, conduct problems gets more severe in the teenage years. You see a lot of naughty in the prepubertal ages. Bipolar disorders, late teens and young adults. Personality disorders, conduct disorders, substance abuse. Those are all things that you see in late teenagers and young adults. So depending upon when the person is coming to me, there are only a certain number of conditions that I really need to worry about. These lines are here because essentially what happens in my business is I get a history of a kid was going along fine until. He was doing fine until. He was doing fine until. And these are conditions that take them out of their developmental trajectory. So if you've got a youngster who's kind of humming along and everything's going okay, and then all of a sudden they fall off their trajectory, the goal of clinicians like myself is to figure out what took them out of their game, what helped them fall off that trajectory. And there are limited numbers of things that do that, and those things occur at specific times. You know, if you know where you're headed and where the risks are and what it's about, if you know what your family history is for anxiety and depression, if you know how old your kid is, if you know when these symptoms tend to present and what they look like, you're going to be there ready to go. You're going to get early intervention. And we now know, especially for depression, that the faster you get people better with depression, the better they do. The longer you wait, the more disability they accumulate. The longer you wait, the harder they are to treat. The longer you wait, the less frequently they remit, meaning have complete resolution of symptoms. So people like to wait on psychiatric disorders. Like, you know, can we sit on this psychiatric disorder for another 2 or 3 years? Maybe it'll go away. Let's cross our fingers. Let's talk ourselves into just waiting and not paying attention to it. Bad idea, guys. You know, it's like we have a lawyer, we have an accountant. You got to have your family mental health professional. And that person should know your genetics pretty well, your family history stuff. They should know your kind of strategies and ways of living. and they can really help you and be available to you over time to kind of get in early when you need to. This is another one. ADHD confusion, we see this a lot. Right here, between the ages of 4 and 7, every one of these conditions presents with wiggling, squiggling, and inattention. And the ADHD people have done such a really good job of educating the public that every kid who wiggles and squiggles between ages 4 and 7 gets an ADHD diagnosis and gets stimulant medication. But if you look at how complicated all these little lines are, good diagnosticians are going to be looking for these conditions, which unfold, if you will, in this time course. Does that make sense? Just like what we talked about. But right here between 4 and 7, it's kind of a maze, difficult to kind of sort. So you need somebody who can kind of do this developmental sorting. And that's why, you know, if it's leaning more towards a pervasive developmental disorder or more towards an anxiety disorder, the people who can help you sort that may not necessarily be an ADHD doc. So you just need to be aware that when you talk with medical professionals, that you're talking with people who are trained in a particular area. And what I'm trying to do is say, listen, you got to sort and sift a little bit. You've got to pay attention. Since most patients and parents with Tourette syndrome know more than their doctors do about the condition because they've spent hours and hours and hours and hours on the internet, you know, use that, put that to good advantage so that you work closely with your docs, kind of share information with them, get them going, and realize the kinds of inadvertent, these are not terrible mistakes, these are just inadvertent mistakes. Problematic assumptions. He can't control it. Oh, man. There's a whole generation who grew up with that. They can't, but that whole concept generalized to every other behavior. He can't write, can't think, he can't learn, he can't control his anger, he can't sit at the table, he can't use the toilet right, he can't clean his room, he can't participate in sports, he can't share with his brothers and sisters. Can't control that because it's all part of... Ugh. We are working really hard to redo this and say, yes, they can't control the motor movements, but you know what? They probably need to work on controlling everything else that they can control and getting really good at it. Kids with ADHD, well, that's his problem. He can't control the ADHD. I said, well, yeah, but then he's got to be disciplined in every other way so that he has a chance with his ADHD and his Tourette's to be successful. So it's not about cutting them slack. It's about developing a program to make them extremely competent despite their difficulties. Does that make sense? That's, from my point of view, that is holistic. It is looking at what kids can and can't do, figuring out ways to manage the problems where they really struggle, but really trying to maximize their strengths to get them functioning at their highest level so that when they face difficult situations with their ADHD or their Tourette, they're ready to go. They've got the equipment and the training. I can't set limits on him. That's this thing that happens to parents. They just feel so bad. They feel guilty. Ugh, my goodness. And once kids get the whiff of that, he has a tough life. I want it easy for him. You know, if your other children are saying, Mom and Dad, you know, you've been hooked by this one, he's running you ragged, trust him. Those other kids know. Those other kids know when you've gotten caught up in a situation where that youngster who has problems is also working those problems, if you will, to kind of impact their interactions with you. Special accommodations. I'm a firm believer in special accommodations, but I've also seen harm done with special accommodations. Medication is the answer. Oh my gosh, I hope you hear today that we are so far away from talking about medicine right now. There's so much more that can be done on the non-medication front to improve the lives of kids. What you see of Tourette on TV or on YouTube is what TS really is. It scares the living daylights out of people who have seen Tourette, who have new onset tics. Then they go on the television, they see some of the more severe examples. And then the other one is it's all TS related. It may be, but there's consequences to that don't work very well. Anxious kids have physical complaints. Headaches, stomach aches, back aches, moans, groans. I call it a midline disease. Gagging, choking, swallowing. If your kid has Tourette and he can't swallow his pills, Lump in the throat, right? We all get a lump in the throat sometimes. Anxious kids not only have a lump, they have a softball sitting up there. You ask them to swallow a pill past that softball, they get really, really uncomfortable. They worry about vomiting, they worry about gagging, they worry about not being able to breathe. They have stomach upset, they have respiratory problems, they have cardiac issues, they have bowel and bladder issues. They always have to pee before some stressful experience. So they're always the kid who raises his hand and has to leave the classroom prior to a test experience. Anxiety is a midline physical symptom disease. If you've got a kid who's got midline things, you'll see anxious kids presenting with physical symptoms. Headaches, stomach aches. These kids are often sick in the morning and can't fall asleep at night. So if I have an 8-year-old who is sick in the morning routinely but looks pretty good by 1 or 2 years of age, or 1 or 2 in the afternoon, I'm thinking anxiety disorder, especially if it takes him 30 to 40 minutes to fall asleep at night. He needs a parent in the bed giving him a back rub. All of that kind of stuff speaks to the anxiety disorders. These kids frequently urinate or defecate. They get shortness of breath. They have chest pain or rapid heartbeat. The sensitive gag reflex, this is that lump in the throat the size of a softball, and they fear choking or vomiting. Anxious kids are smaller. So if I see a kid with tics who's small for his age, on the skinny side, picky eater, can't fall asleep, recurrent stomach aches, got the picture? I'm in the anxiety ballpark. I am not in the Tourette ballpark. I'm not in the tic ballpark. Dizzy and lightheaded. Don't see that much in young kids, mostly in older teens and young adults. Tension and tiredness at night. Most kids after school come home with a lot of energy and want to explode with play. Anxious kids come home and take to the couch. They've had such a hard day. They've been working so hard, managing everybody's expectations. If you're seeing a kid, a 6, 8, 10-year-old kid, being tired after school, he's got an anxious burden. Some people will say, well, school is too stressful. But I'd say, well, yeah, maybe too stressful for your youngster, but what about all the other kids in the class? Is it too stressful for them too? Maybe it's your stress tolerance, which has to do with a kind of underlying anxiety disorder. So I reframe that idea about it's outside stress to whether it's inside anxiety management, stress tolerance stuff. Derealization and depersonalization, these are kind of funny symptoms that people with anxiety get. Depersonalization is that experience when you're at a party and you spill something on somebody else and you become disembodied from yourself. You stand over here and you look at yourself and call yourself a jerk because you just spilled on that person. And so there's 2 of you at the party. One's critical of you and the other one's embarrassed. Derealization is that experience that sometimes you get when you're in a near-miss car accident. All of a sudden your head just is kind of wobbly. You just feel kind of disconnected. You just don't know where you are or what you're doing because you've just had a very stressful kind of traumatic, anxious experience. And you don't feel real. The world around you feels kind of bizarre or strange. Just think if you are 8 years old and you're trying to describe these symptoms to somebody, you'll sound crazy. So these kids get ascribed to being crazy or nuts. If you have Asperger's syndrome or autism, oh my gosh, those kids really sound very, very disturbed when they're trying to describe this. Avoidance to prevent any of the above physical symptoms. The big crippler for anxiety, other than the fact that it feels terrible to have, the big crippler is that people develop avoidance coping. Their strategy for living is to not do whatever they think may make them uncomfortable. So their lives get smaller and smaller and smaller. And as a result of that, what happens is they don't develop rich, robust coping and adaptation strategies about how to manage unexpected situations. And that's what's crippling to people with anxiety over time, is that they don't develop that rich, robust coping strategies. They use predominantly avoidance coping. When you're 15, 16, and 17, if you use avoidance coping, like avoiding high school homework, avoiding class trips, avoiding peer relationships, got what I'm saying, spending too much time with video games, all of a sudden that youngster, when they really do have to perform socially or academically, they're going to be challenged because they need a robust coping system to manage all of those adolescent challenges. And if they didn't get treated for their anxiety as a youngster, then they go into their teenage years, in some respects, with less well-developed adaptation and coping. Secondary behavior problems. Children, I talked about this, they're more difficult to parent. Parents are extremely uncertain. And you know what? Kids with Tourette are less responsive to routine parenting. No surprise there. They're harder to parent. They've got something that makes it difficult for them to be parented. And the other part is that parents will then attribute that he can't really be responsive to routine parenting stuff. And so this cycle of poor parenting, poor discipline, poor structure begins to ensue. The other thing we see much less now than we used to see before, but when I first got in the Tourette syndrome business, families were trying to get their kids to be poster children for Tourette. They were trying to use Tourette as a core component of a youngster's identity. So it's like, hi, I'm Billy and I have Tourette syndrome. That was kind of how the kid was conceptualizing themselves, going to school with that, educating everybody else about doing that. We still want kids to be able to do that. But increasingly, I want the kid with Tourette to say, hi, I'm Billy and I'm good at softball and I'm good at mathematics and my mom and dad are a lot of fun when they aren't arguing. And to say a million other things about his concept of himself other than he is a person with Tourette syndrome. You need to do that. You need to self-advocate. But the best advocacy for kids is about what they're good at, what they like, and what they can bring to a peer relationship, what they can bring to a classroom, how they can make a teacher's class better for that teacher. That's what you want kids to have an identity built around. And you know what? That's all in our control to help them do. We can't take their tics away. We can medicate them away. We can use behavioral treatments, but we can't take it away. We can help them build that rich, robust identity, coping, and adaptation strategies that will allow them to survive with whatever deficits they have or difficulties they have. So core elements, they're kind of constitutional endowment, family relationships, academics, peer relationships, and leisure activities. This is one we forget a lot about. Kids who can occupy themselves and keep themselves entertained with non-video games, it's a big deal. Problems living with TS. So there's actually groups of people who have had a completely different experience growing up with Tourette. So if you talk to people who are in the 40 to 70 age range, they didn't know they had it and were oftentimes stigmatized for it, had a hard time getting a job. They were oftentimes put in treatments that weren't effective for it. Pretty bitter. This group can be pretty bitter. 25 to 40 was eliminate all tics with medication. These are folks that grew up in the Haldol era. They got as much Haldol as it took to stop them from moving at all. When they finally had their medicine reduced at 20 or 25, they realized that they lost most of their childhood and adolescence to a medication haze. They're having trouble functioning in the real world now. So from a clinical point of view, when I see young people in this age range, I worry about kind of how they spent their adolescence and how much medicine they were on. This group, the 15 to 35-year-olds, they grew up in the you can't control it. So these are a lot of folks who have real difficulties with behavior and emotion management regulation. And, we used to worry about making kids neurotic, over-controlled, over-focused, compulsive about what they do, kind of rigorous. You know what I'm saying, Woody Allen-like neurotic. What we've traded in for is we've traded in for a group of young people who have poor emotion and behavior regulation. And I hire people who are neurotic. I actually like people who are neurotic. They always show up for work. They even come a little bit earlier. I don't hire people who have problems with emotion and behavior regulation. This is a group of folks that grew up in a period where part of our treatment was to say to them, you can't control yourself because you've got a neurologic condition. And even though it was meant to help, it didn't really focus on what can you control to make your life better? What can you control to participate in leisure activities? What can you do to function at a higher level within your family? What can you do to make more friends? Let's work on all that stuff because that's family stuff. That's things that moms and dads have been doing forever. But it stopped for a period of time in this age group. It may be TS, but the tics are not the biggest issue. That's kind of where we are now. And me, personally, outcome is associated with severity of comorbid conditions, self-control, and the courage to overcome adversity. That's my treatment plan. It's all up here. It's all up here. In medical school, we saw this lady who was born with no arms, and they showed what a day in a life was like. She drove a car, wrote a check, put a necklace around her neck. They showed her washing dishes, cutting up food in the kitchen, all with using her feet. She never had a sense of being disabled. Never had a sense. And at the end, they show her, actually she's preparing dinner because they followed her through the day in the life. And you see this fly kind of flying around the kitchen. And you see her put the knife down, taken out from between her toes, 2 feet up, get the fly, pick the fly. So I don't know if that was a video trick or not, but when I think about what it is to have some kind of life difficulty and the way to kind of manage it and overcome it, it is about everything else but that. Does that make sense? So if we're talking about anything here today, it's about, okay, you got it, fine. Let's find the right treatment. Let's make sure we understand the complexity of the individual person's stuff so we got it really defined well. But then let's focus on ways of living, coping, and adapting that are going to make you heroic in your living as opposed to disabled or dysfunctional in your living.